And we're back. So, we'll now proceed with the second part of the female reproductive endocrinology. So, as we were talking about earlier, the ovaries are essential to the production of your estrogen and progesterone, and the level will depend on which part of the female reproductive cycle the female is in. So, your estrogen can be synthesized from three different sites, not just from the ovary, but that's the main source of your estrogen. So, your estrogen can be secreted either directly from your ovary in reproductive age women, or it can be from the conversion of your circulating androstenedione either from the adrenal glands or from your ovary, and your androstenedione will now be converted in the peripheral tissues, okay, to your to your estrone E1 to your estradiol E2, or it could be within the estrogen target tissues itself, the conversion of your androstenedione to your estrone, and then later to your estradiol. So you have three sites of estrogen biosynthesis in women, not just in the ovaries, also in your peripheral tissue, specifically your adipose tissue and your estrogen target tissues. So again, to review the synthesis of your estrogen and progestin, particularly your progesterone. So the main substrate would be your cholesterol, and the cholesterol will be acted upon by STAR to, to help its entry in the inner mitochondrial membrane, and your cholesterol desmolase, the second rate limiting enzyme in ovarian steroidogenesis, will now convert your cholesterol to your pregnenolone, and your pregnenolone will now be converted to your progesterone. And your progesterone can either be released into the circulation or converted into your hydroxyprogesterone, and then eventually be converted to your androstenedione, or your DHEA can be converted to your androstenedione, and your androstenedione can now be a precursor either of your testosterone or directly converted by your aromatase to estrone or to estradiol, and in the liver it will now be metabolized into your inactive estriol. Okay, so that's how your um, estrogens are metabolized. So the site of metabolism is in your liver. So that's why in patients with liver pathology, such as your chronic liver disease, the metabolism of your estradiol is impaired. So these patients with chronic liver disease can develop gynecomastia because your estradiol cannot be metabolized efficiently. So the establishment of a functional GnRH system is very crucial into the normal development of your female reproductive organs. So remember, similar also to your males, your GnRH neurons will, during fetal development, will migrate from the olfactory placode to your hypothalamus, and when your GnRH neurons are able to reach your hypothalamus, it will now be start secreting your GnRH, and your GnRH now will act on your GnRH receptors in your pituitary, stimulating the release of your gonadotropins LH and FSH. So if you have mutations such as your CAL1 gene, your FGFR8 or FGFR1 gene, and so on and so forth, if these genes are defective, then you can have the failure of migration of your GnRH neurons into your hypothalamus, and you can have your Kalman syndrome. So your FSH and LH secretion can vary during a lifespan, and this is very similar also to your testosterone. So if you can recall that testosterone, the levels would vary depending on the life on which part of the lifespan the patient is in. So the FSH and LH are increased, of course, during the neonatal years here, but so the green lines represents the levels of your LH and the broken red lines represents the level of your FSH. And they are increased during the neonatal years but go through a period of childhood quiescence where there's not much development of your reproductive system until your internal clock turns on the development of or the onset of your puberty. And during the puberty, it will start to increase and will now start um, cyclic fluctuations during the entire reproductive years. And when your ovaries undergo menopause, there will be a reduction in the production of your estrogen, and the reduction in the progesterone of your estrogen will now have a loss of negative feedback to your LH and your FSH. So in the menopausal years, you will have high levels of your LH and FSH during menopause. So here are the different effects of your estrogen in the breast. It contributes to the development of the stromal tissues of the breast, growth of the extensile ductile system, as well as deposition of fat in the breast. It also has significant effects on your skeleton. So your estrogen is an anabolic hormone. So it inhibits osteoclastic activities in the bones and therefore stimulate bone growth. That's why it's anabolic. Remember, in your bone remodeling, your osteoprotegerine inhibits the maturation of your pre-osteoclast into your osteoclast. So your estrogen has a positive effect on your osteoprotegerine. Therefore, inhibiting the maturation of your pre-osteoclast to your osteoclast, thereby inhibiting bone resorption. And your estrogen also has an effect of your epiphyseal closures with the shafts of the long bones of the body. So your estrogen also has effects on total body protein, slight increase in body metabolism. There's increased deposition of fats in the breast, in your subcutaneous tissue, in your ass, in your thighs, and but your estrogen has, unlike in males, will have very little effect on your hair distribution. It's more of your adrenal androgens, particularly your testosterone, that would have an effect on your hair distribution. Your estrogen will also have an effect on your skin, makes it look more soft and with smooth texture, and also has an effect to a certain degree in your electrolyte balance, similar to your testosterone. Your progesterone, on the other hand, will have effects mostly on your uterus, your fallopian tubes, and your breast. So in the uterus, it promotes the secretory changes in the uterine endometrium and prepares the uterus for implantation of the fertilized ovum. And it decreases the frequency and intensity of uterine contraction, therefore preventing the expulsion of the implanted ovum. So it sort of relaxes your uterus so that you will not have a threatened abortion. Your fallopian tubes. In the fallopian tubes, your progesterone increases secretion of the mucosal lining. So essentially, it really helps facilitate a successful pregnancy. So if you have problems with your progesterone levels at the initial days of your pregnancy, then you can have early pregnancy loss. In the breast, it promotes the development of the lobules. So the estrogen is for your ducts and your progesterone are for your lobules. And it also causes the breast to swell. That's why when you're about to menstruate, when the progesterone levels are high, you will feel some breast and a little bit of breast swelling and discomfort. So the reproductive system in women is critically dependent on the negative feedback of your gonadal steroids, your estradiol and your progesterone, as well as your inhibin A and inhibin B to modulate your gonadotropins LH and FSH. And your inhibin mostly is affected by their levels of your FSH. Okay? And the reproductive system is also dependent on the positive feedback of your estrogen to your anterior pituitary so that you will have the pre-ovulatory LH surge. So you have both negative feedback and your positive feedback. So puberty happens and different things happen during your puberty. So you have your adrenarche or the appearance of your pubic and then axillary hair, and this is mostly because of the increase in the secretion of your dihydroepiandrostenedione from your adrenal glands. And you have your telarche or the start of your breast development, and lastly your menarche or your first menstrual period. So in the puberty, the menarche would be the last one to develop. So the development of your pubertal milestones can also vary with your race. So here are the differences. Okay. So the hormonal events that happen during puberty is illustrated here. So look more closely on the illustration on your left. So depending on the patient or the female's internal clock, there will be something that will trigger the start of puberty. And the start of puberty will now generate the start of your GnRH pulses, and your GnRH pulses will now stimulate the secretion of your pituitary gonadotropins at a higher level. So there's an increase in your FSH and your LH. It will now stimulate both your adrenal glands as well as your ovaries. But mostly it's your ovaries that play a lot of role. So your ovaries and your adrenal glands will start producing your androgen. So in your ovaries, your estrogen is increased and your progesterone is produced by your corpus luteum, and your estrogen and progesterone will now have all these effects. So your acne will start to appear, your axillary hair will start to grow, breast will start to develop, and your uterus enlarges, and your menarche starts. Okay, and you will have the development of your pubic hair. There will also be some changes in your vaginal epithelium as well as changes in body shape. So your pelvis will become more wider and rounder. And lastly, you will have the union or your epiphyseal closure, which is facilitated by your estradiol. So pathologic states of puberty could either be precocious puberty or the early development of your secondary sexual characteristics, and this is defined as the puberty before the age of 8 in girls. So when to evaluate for precocious puberty, if there's breast development or pubic hair development at less than 7 years of age for white girls or less than 6 years old for black girls. So look at this baby, this little girl, also already has a breast mound, and this is not normal. This is pathologic. This is a manifestation of precocious puberty. On the other end of the spectrum, you also have delayed puberty or the absence of secondary sexual characteristics by the age of 13 in girls. So the causes of this will be mostly from ovarian pathologies. So here are the differential diagnosis of your precocious puberty. It can be either GnRH dependent or central, or GnRH independent, meaning the problem is either in your adrenals or in your ovaries. or some resistance in your receptors. So if it's your hypothalamus or your pituitary that's the problem, then you have failure of your GnRH or your gonadotropin production. If it's GnRH independent, you can have congenital adrenal hyperplasia, failure of your androgen secretion, depending on which enzyme is involved. Then you can also have some estrogen producing tumors, either your congenital adrenal hyperplasia, you will have androgen overproduction because of a block of in the production of your glucocorticoid or your mineralocorticoid pathway. If your patient has adrenal tumors or ovarian tumors, you will have an excess in estrogen production, and so on and so forth. How about for delayed puberty? So you can differentiate. You can have two types of causes of your delayed puberty. You have your hypergonadotropic, meaning you have a problem in your ovaries on your adrenal, causing an elevated LH and FSH when you do your biochemical testing. So if the problem is your ovaries, it can either be Turner syndrome, gonadal dysgenesis, or things that destroy your ovaries, such as your chemotherapy or RT, and so on and so forth. Or you can also have androgen resistance syndrome. So you have the receptors for your androgens are not working properly, so therefore estrogen cannot act on your target peripheral tissues. What else? If the problem is central, then you will have a hypogonadotropic type of delayed puberty, meaning the problem is either in the hypothalamus or in your pituitary, and the classic condition would be your either idiopathic hypogonadotropic hypogonadism or your Kalman syndrome. So this is an illustration of your Tanner staging in your female. So please concentrate here. For breast development, you will see the development of your breast bud, and then there will be an additional enlargement until you have the mature morphology of your breast. Of course, the sizes will vary, which can be affected by mostly genetics. Then these are the appearance of your female pubic hair development. So at the beginning, you will have you have the Tanner one will be there will be very 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 few pubic hair, and then it will start to grow starting from the inner portion, and it gradually spreads into the outer part of your labia, and then it will start to grow until you have your adult morphology of your pubic hair. So aside from your Tanner staging, we also have your Ferriman-Gallwey scoring, which is a scoring system to evaluate hirsutism. So because hirsutism is one of the ways by which you can tell whether you have androgen excess, particularly your testosterone. So you can grade whether your patient has hirsutism or not, depending on the distribution and amount of hair on certain areas of the body. So this is mostly population specific also. So you can have your own Ferriman-Gallwey scoring among Indian. I don't know if you have in the Indian population, because you are compared to Asians, you compared to Southeast Asians like Koreans, Japanese, and maybe even Filipinos were less hairy compared to our South Asian counterparts. So now we proceed to the disorders of the female reproductive system. So most of the common complaints of females seeking consult for reproductive problems would be your chronic anovulation. So chronic anovulation usually present with secondary amenorrhea, meaning you've had your menarche and then later on you fail to develop your monthly menstrual cycle. It can also present as infrequent uterine bleeding. If before you're usually every month on the dot, then you will have intervals of 3 months, 4 months, 6 months. Some females would have menses only once a year. So that's also a symptom of chronic anovulation, or you can have irregular episodes of excessive uterine bleeding. That's also a symptom. So the obvious consequence of chronic anovulation is of course infertility. And in order for you to be able to narrow down your differentials quickly, then you can think of chronic ovulation as either of these different general categories of causes of chronic anovulation. So you have hypothalamic anovulation, you have hyperprolactinemia. Of course, your prolactin will cause a suppression of your GnRH. Therefore, you will have low FSH and LH. Then you can have chronic anovulation. Then you can have also androgen excess. You also have primary ovarian insufficiency and also your chronic illness. So if the problem is in your hypothalamic pituitary unit, the most common is your functional hypothalamic anovulation or your functional hypothalamic amenorrhea. And this is usually very, very common in young female athletes or young female ballerina who are under a lot of stress, who's always on dieting, very thin patients, or those who are required to do vigorous exercise, as I mentioned, athletes, or those with chronic illness. Some patients can have chronic anovulation because of psychiatric medical emergencies such as your anorexia nervosa. So this will have an impact on your hypothalamus and all these other things also. Okay, so because of the chronic anovulation, some of this will have an effect on your bones, primarily on your osteoporosis. So the treatment will be the reversal of your primary cause, of course. If the chronic anovulation is caused by androgen excess, then the most common will be your polycystic ovarian syndrome. Very common, your PCOS, and your PCOS is associated with elevated testosterone or androgen secretion. A variant of PCOS would be your hypertrichosis, ovarian tumors. Other causes of androgen excess would be adrenal origin such as your non-classical adrenal hyperplasia, Cushing's, etc. So on and so forth. And then, so this is a picture of a patient with severe hirsutism. As you can see, this patient would have hair here. Usually this is more common among males, and some hair over here and here also. This one is a patient with severe hirsutism. This looks like a male already, male beard, and this one requires regular shaving. This one is hirsutism in the chest. So this looks like a male pattern, but these are actually females. So in order to evaluate this, you score with your Ferriman-Gallwey scoring. So this one is a patient with a testosterone-secreting ovarian tumor, and since the oversecretion of your testosterone is occurred after puberty, its effect would be mostly on the size of your clitoris. So of course, it cannot stimulate you to grow a penis or grow a scrotum, but the effects would be an enlargement of your clitoris. Okay, so if you measure this, the entire length of your clitoris is about 4 cm. The normal would be less than 1 cm. So we go to the last part, which is your menopause. So the most common symptoms would be mood swings, hot flashes, night sweats, irregular, then your patient will start having irregular periods and loss of libido, and then you have vaginal dryness. So around the time of your menopause or your perimenopausal period, you will have some changes in your androgen, in your estrogen levels, as well as change also in the FSH and FH due to the changes in the negative feedback brought about by the changes in your estradiol and estrone levels. So as your estrogen and estradiol start to drop, your LH and FSH start to rise. So that's why one of the tests that you can use to determine whether your patient is already in menopause is to test your FSH, and at a later time you can also test LH, but usually it's FSH that we test. So who are the patients that require postmenopausal hormone therapy? Well, you have to weigh the benefits and the risks. There was a time when hormone replacement therapy was a norm, but then they did the Women's Health Initiative study where they evaluated the benefits and risk of postmenopausal hormone therapy among patients 50 to 79 years old, and there were some definite benefits, mostly in the symptoms of menopause and improvement in osteoporosis. So the relative benefit would be a 65 to 90% decreased risk of symptoms of menopause and a decrease in risk of hip fracture by about 33%. But they found out with this study that there are definitive risks, such as an increased risk of endometrial cancer, an increase in some thromboembolic events such as your pulmonary embolism, your deep vein thrombosis, as well as an increased risk of your breast cancer and gallbladder disease. So the decision whether to do your hormonal replacement therapy will have to depend on the profile of your patient, whether the patient needs the benefits or whether the patient is at increased risk of developing um, the thromboembolic events as well as your breast and your endometrial cancer. So how to weigh things? If the patient has significant symptoms of menopause, then you can consider hormone replacement therapy. But if no symptoms, then don't replace. If you have symptoms, then you have to know if the patient has no contraindications. If there are no contraindications, then you can um, assess cardiovascular risk. If very low cardiovascular risk, then you can do hormone replacement therapy in order to alleviate symptoms of menopause or decrease the risk of osteoporosis. But if you have a high cardiovascular risk, then you avoid hormone replacement therapy. So the traditional contraindications to hormone replacement therapy are this: okay, unexplained vaginal bleeding, active liver disease, history of venous thromboembolism, a blood clotting disorder, or history of breast or endometrial cancer, as well as diabetes. So, if your patient has all of this, don't even think about starting hormone replacement therapy. There are other ways of controlling postmenopausal symptoms or menopausal symptoms. So, to summarize, here is a summary. So, you just read this and then I'll see you next week for our part 2 of our flipped class. So, we'll have a quiz and discuss the cases pertaining to the female reproductive system. Have a good day. Bye bye.